Well, hello. I'm Denis Roy. I'm very pleased to welcome you to this webinar. We're expecting about 30 participants, and I think we have half of them now on the line. So I will start with the first slide. I will only talk about the first two slides. Brain AF is, just as a reminder, is the first randomized trial which aims to prove a causal link between atrial fibrillation and cognitive impairment. The Brain AF trial has the potential to establish if anticoagulation improves cognitive outcomes in AFib patients with a low risk of stroke. I believe the trial is both timely and very important. It has the potential to change the practice of medicine and people's life. It's a very important trial, and I believe we're your contribution is important to make this trial, complete this trial as soon as we can, at least for the enrollment. And like most important trials, they often have good acronyms, and I certainly want to thank Paul Carey for thinking of this acronym. And so I can have the second slide, please, which is, this is just to illustrate that the Brain AF has received very recently a grant from the CIHR with excellent comments from the reviewers. And for this, Lena Rivar has to be, she is, as you know, the PI of the study, has devoted a lot to this trial, and I believe this just represents the success of all this work, and not only from her, but from the whole team. So I'm very happy with this, and with that, I let Lena bring you up to date on the trial. And as you'll see, the important changes have been made to facilitate both recruitment and follow-up of the patients. Thank you.
Thank you, Dr. Roy. So next slide. So I'm Dr. Lena Rivar, and I will present today a short update of the trial. So we think there is a connection between silent cerebral ischemia and cognitive decline in young patients with atrial fibrillation, and that oral anticoagulation could help reduce brain damages in this population. You're seeing here a cerebral MRI of a young patient, 55 years of age, with atrial fibrillation, paroxysmal atrial fibrillation, and a low risk of stroke, so it doesn't have any indication for oral anticoagulation. He was sent to us by his neurologist because he was diagnosed with mild cognitive impairment. As you can see here, you see multiple areas of small brain infarcts, and his cognition stabilized after anticoagulation, but he was not able to regain his previous cognition status. Next slide. So in the Brain AF trial, we do randomize patients with young patients, 30 to 62 years of age at consent. They can be in the trial until the age of 65. At the age of 65, as you know, even if they are in the absence of any stroke risk, we need to start anticoagulation therapy. So patients, they have a low risk of stroke, basically CHADS 0 with younger than 62 years of age at consent. Documentation of atrial fibrillation within the prior 2 years. So it can be either EKG, intracardiac electrocardiogram, but it can also be any rhythm strip. So that is important to know. Next slide. Main exclusion criteria, obviously indication of oral anticoagulation therapy or antiplatelet therapy or an increased risk of bleeding. Since the last amendment, a plan to perform AF ablation is not a criteria for exclusion anymore. So if you think the patient will need AF ablation, or if he's on the waiting list, he can be included in the brain AF trial. Next slide. So this is a study design. Patient meeting inclusion and exclusion criteria. They undergo a cognitive testing, so a MMSE. They are excluded if the MMSE is lower than 25. And after the MOCA, quality of life, Beck questionnaire, that is a depression questionnaire. And they are randomized 1-to-1, rivaroxaban 15 a day, or standard of care. So placebo for most of the patients, we have only less than 5% of the population with vascular disease in this population, subset of the population, asafen. We're giving asafen in the standard of care arm. Yearly visits, and the primary outcome is a composite outcome, neurocognitive decline, measured by a decrease of the MOCA score of at least 3 points, stroke, or an TIA. So what is important here is that we know that a decrease of the MOCA score of at least 2 points is significant, but we did choose to be stricter in the brain AF trial, so we choose a 3-point cutoff. For TIA, only aphasia or motor deficit are considered as a TIA. This is an event-driven design trial, so we need around 2,000 patients to complete the study. Next slide. So those are the events so far. Obviously, for the total blinded population, we saw 6.5% of cognitive decline, so a decrease of the MOCA score of at least 3 points. And this is higher compared with what we did expect at the beginning of the trial. And we had 1% of stroke in the total population, or TIA, 4 stroke and 1 TIA. Next slide. So safety events, we had 0.5% of major bleeding, so 4 patients, 1 post-surgery bleeding. The patient was off drug therapy for at least 3 months prior to the surgery, 1 aneurysm, 1 frontal hematoma, 1 ocular hematoma. 2 patients were started on study drug therapy few months after the event. We had 2 deaths, so 0.25%, 1 suicide and 1 motorcycle accidents, and we didn't have any intracranial bleeding in the subpopulation so far. Next slide. So to simplify recruitment and follow-up, we had the last amendment, Amendment 7, which was approved by Health Canada beginning of 2021. It does allow more flexibility for recruitment and follow-up. Recruitment and follow-up can both be done remotely now. So we can, for example, the consents can be signed via email through the DocuSign platform. Baseline visit can be performed remotely. So do not forget that for baseline on the final visit, you'd need both the MOCA and the MMSE score to be performed, and they should be done with a minimal interval of 1 hour. So you can either have 2 remote sessions the same day, or you can choose 2 different days, or you can have 1 part of the visit done remotely and 1 face-to-face. You just use what is convenient for you, your center, and the patient. Next slide. So for the yearly visit, obviously can be done also remotely. We don't need anymore the blood test at the 6-month visits. And the yearly blood test can be done around the patient house. We do not need yearly EKG anymore, only a rhythm strip. And the patient can record his vital signs himself. So blood pressure, weight, and height can be recorded by the patient. Next slide. To increase recruitment, we are in the process of launching the Brain AF website. So it should be available in 1 month, we think. And patients can go through the website. Patient interested and eligible can go through the website and send an email, and they will be referred to the nearest center for recruitment. We also have an email address for cardiologists who wants to refer eligible patients. Next slide. So we have now 40% of the study completed. I want to thank all centers in Canada. And preliminary results show an increased risk of cognitive decline in this very young population, and safety of oral anticoagulation in this population. And next slide. Special thanks to the 10 best sites in Canada. They are listed here, so thank you very much to those and others. And I will let my co-PI, Dr. Paul Kerry, present the baseline data.
Excellent. Thank you very much, Lena. And good evening to you all. We're really delighted that you can join us this evening for this webinar. And we thank you for your implication in the BRAIN-AF trial. If you have any questions that come up, I see that some of you have already started entering in some questions, but please do feel free to use the chat function or the question and answer function, and we'll get to the question and answer period shortly. So next slide, please. On behalf of the BRAIN-AF trial team, it's a real pleasure for me to present to you some of the analyses on our baseline characteristics. It's important to note that these analyses are based on data that is blinded. So we do not know which patients received rivaroxaban and which patients received placebo. But nevertheless, I think there's some interesting findings. So if we look at the characteristics of our first 694 patients enrolled in the trial, you'll note that the average age is 53 years, which makes the BRAIN-AF trial the trial with the youngest population of patients with AF randomized to anticoagulation therapy. Now, despite the young age of this patient population, if you look at the third row, you'll note that that 14.4% of our patient population has a MoCA score less than 26, which is the cutoff for mild cognitive impairment. And this is quite significant because when the BRAIN-AF trial was initially conceived, one of the criticisms we received was that the patient population might be far too young to detect any cognitive pathology. And that is clearly not the case. 100 out of the first 694 patients have MoCA scores that would qualify as mild cognitive impairment. Next, if you look at the pattern of atrial fibrillation, you'll note that 73% of the patients have paroxysmal atrial fibrillation, which means that 27% of patients have non-paroxysmal atrial fibrillation, which is about equally divided between persistent and permanent AF. And we'll get to that a little bit later in the following slides. But as Lena mentioned, in this young population of patients who do not have standard risk factors for stroke, you'll note that the prevalence of vascular disease is quite low here, less than equal to 4.6%, so less than 5%. Next slide, please. So the first study that we conducted on these baseline characteristics is a cognitive function substudy. And here I should highlight the important role of Dr. Louis Barrère, who I believe is actually on this webinar. So Louis, if you have any comments, just enter them there and I'll be happy to read them out. But Dr. Barrère is a professor of psychology and an eminent researcher specialized in cognitive function. And so he oversaw this study along with his PhD student, Tudor Vrinsanu, who really did the lion's share of the work here. Now, I think one of the most important findings of this sub-study is that in multivariable analyses, that is after we control for factors such as age, sex, level of education, body mass index, depressive symptoms, well, non-paroxysmal atrial fibrillation So permanent and persistent atrial fibrillation was independently associated with a significantly lower MoCA score than paroxysmal atrial fibrillation. And this is a very interesting finding because, as Dr. Roy mentioned in his introductory remarks, there is now a wealth of observational studies that is showing this association between atrial fibrillation and cognitive dysfunction, but a causal relationship has not yet been demonstrated. And if one considers the criteria to establish causality, well, one of the elements that is considered strong evidence is the demonstration of a dose-response relationship here, which is essentially what we're showing, because patients who have a higher atrial fibrillation burden have lower cognitive function scores. If you could just please click to see the second half of the slide. Thank you very much. Now, as interesting as that may be, we took the analyses one step further. So as you all know, the MoCA score is a score that assesses global cognitive function, but it contains several different domains that comprise that MoCA score, including domains such as executive function, short-term memory, and language abilities, and so on. And so while we observed that patients with non-paroxysmal AF had a higher burden or a higher degree of cognitive dysfunction, well, the next question we asked is what domains within that MoCA score are affected most in our patient population, and what could that tell us in terms of insights into potential pathophysiological mechanisms? Next slide here. So in this rather busy slide, but I'll walk you through it. What we're essentially showing is a plot of MoCA Z scores in patients who have paroxysmal atrial fibrillation in black, and non-paroxysmal atrial fibrillation are represented by those gray bars. And so if you look at the very first column on that slide where it says global, that is our comparison of the overall MoCA score. And as previously mentioned, you'll see that there's a statistically significant, highly significant difference here between patients who have non-paroxysmal AF with a lower MoCA Z scores compared to those who have paroxysmal AF. Now, the following columns are those same two-group comparisons between paroxysmal and non-paroxysmal atrial fibrillation, but according to the different cognitive domains. And you'll notice that for some of these cognitive domains, if you look 5 columns down the slide, in the middle of the slide, if we look at language, for example, and abstraction, that's right next to language, there really is no difference between these two groups. Now, the one domain that stands out most is that second column, the visual executive domain. If you can just please click there, excellent. So you see that red circle around that. So that is the domain that really stood out. And what our experts, including Dr. Louis Barrère, are telling us is that this pattern that we're observing is consistent with a vascular pattern of cognitive impairment, where it is the executive functions that are affected most. So if we were just to contrast this, for example, with patients who have mild cognitive impairment that then progresses towards Alzheimer's disease, so a type of non-vascular dementia, well, the pattern that is seen in these types of cognitive dysfunctions are more problems with short-term memory and abstraction, whereas executive functions are relatively spared and intact early on, which is not the pattern that we're observing. So this appears to be a vascular pattern of cognitive dysfunction within a young population of patients in whom the prevalence of vascular disease is actually very low. So this is fully compatible with our cerebral microembolization hypothesis to explain a cognitive dysfunction in this patient population. So to conclude, in terms of insights from analyses of these baseline characteristics, I would say that there are 3 main points. Firstly, the prevalence of cognitive pathology is actually quite high despite the young age of this patient population with atrial fibrillation. Secondly, we're observing a type of dose response effect between the burden of atrial fibrillation and cognitive function. And thirdly, the pattern of cognitive dysfunction that we're seeing is consistent with a vascular pattern of cognitive dysfunction, which again here is fully aligned with the premise of the BRAIN AF trial. So on that note, I'd like to turn it over back to Dr. Léna Rivard, and perhaps we can address some questions. So Léna, some questions now that have popped up. Firstly, this is from Greg Kernew. Thank you, Greg, for the question. What happens if a patient develops hypertension while they're in the trial? Should we at that point discontinue the study medication and begin anticoagulation therapy? So how do we handle these patients?
So per protocol, we should stop the study medication and start anticoagulation therapy in this patient, because there is a need of oral anticoagulation in this patient. The patient will be followed in the trial, so you still need to have a yearly visit for this patient, but obviously on anticoagulation therapy.
Thank you. Another question, as when screening for cognitive impairment, is it better to use the MoCA or the mini mental exam or some other type of exam?
I think this question is related to the worksheet I showed you. It's at the beginning of the trial. What we want is we don't want any patient with dementia in the trial. So to screen for dementia, we're using the MMSE at the baseline visit. But to assess for cognition, MoCA score is more sensible. So we are giving. In clinical practice, so it's in clinical practice. In clinical practice, it's a good question. Dr. Massoud has answered. So he's answering. We recommend starting with MMSE, and MoCA it's more sensitive. So good, perfect.
Okay, great. Next question is about alcohol consumption.
So obviously, alcohol.
Is there a safe level? Yeah.
Yeah, alcohol consumption. So I don't know if there is a safe level. You're asking that to a French, so I don't know. In the trial, we are recording the alcohol consumption. So it's done by questionnaire at the beginning of the trial. Obviously, if the patient has a huge alcohol consumption and you think it's not safe for him to enter the trial, we won't ask that, but we don't have a cutoff per se. What we have is a cutoff with a blood test. So obviously we are asking for a normal hepatic level enzyme, but there is no cutoff for alcohol consumption.
Excellent. And I see another question there, which may be one that our experts in neurocognition might be better positioned to answer. I don't know if Dr. Barrère is still on and might want to type something in there, but the question is, can you give patients a brain age similar to a cardiovascular age or lung age? Tough question.
Tough question. I won't answer. I don't know.
Or perhaps it surpasses our expertise as cardiologists, but yeah. We can consult our experts and get back to you, Greg, with an answer to that. Are there any other questions from other participants? No, I don't see any. So I don't know, Léna, if you would like to wrap up.
Yes. The next slide, please. So you have here all our email and phone number, and the email you can refer eligible patient to. So please do not hesitate to reach us. And I would like to thank you all for attending the webinar. And I hope you are as thrilled as me, from what you're seeing here today. So thank you, everyone. And thank you, Dr.
Excellent. Thank you all for your attention, and have a great evening. Thank you.
Bye.